send all my best wishes and positive thoughts to get over the crisis, and we are all in this together. We will definitely get through it. So, starting with the presentation today, we are going to talk about various kidney manifestations that we observed here during the COVID-19 crisis. I have nothing to disclose besides my 10-month-old son. Just letting you know where I am right now. So we are actually in the northeast of United States, and I'm giving this webinar from North Shore University Hospital. So greetings again from New York. It's a nice bright day here, and seeing bright days coming in future. Just a few things about who we are. So our health system, Northwell Health, it's the New York State's largest healthcare system, which has 23 hospitals and nearly 800 outpatient facilities under it. Since we are the largest system in New York, and as all of you are aware, New York metro area was one of the hardest hit areas by COVID-19 pandemic, especially in United States. So it did not take us long. The first case of COVID-19 here in New York was diagnosed on March 1st, and it just took 3 weeks for New York to become the epicenter of COVID crisis. Our two major university hospitals, the Long Island Jewish Hospital and the North Shore University Hospital, were also the hardest.
It's okay, I got it on mobile, please. Okay.
Okay.
New York becoming the epicenter of crisis, that we actually became epicenter of the epicenter, and COVID-19 just came as a tsunami within days here. So I would like to start with a case. This is an actual case scenario, one of our patients we saw here. A 64-year-old African-American male with no known medical problems presented with 2 weeks of shortness of breath and dry cough, and noted to have oxygen saturation of 83% on room air. He is diagnosed with COVID-19. His initial labs showed a serum creatinine of 7.87 milligrams per deciliter, and because of hypoxic respiratory failure, he was placed on non-rebreather mask right on admission. Within 48 hours of admission, his kidney function and respiratory status both worsened. High-dose diuretics were given, however, were not helpful, and he had to be initiated on hemodialysis. So just going over this case, I'm sure you are also seeing similar scenarios all over the world. So I would just like to take a poll here.
We'll start a poll here. All the participants will get 45 seconds to see the poll and answer the poll. Is the poll visible to everyone?
Yes.
Excellent.
So I would just like to open up this question for everybody participating. What do you think is the percentage of COVID-19 patients that develop acute kidney injury? Or in other words, in how many patients with COVID-19 do you think you would be seeing acute kidney injury?
Five more seconds, please. Hurry up, all the participants. Okay. So, shall I end the poll, Dr. Nupur?
Sure. Thank you.
I'll be soon sharing the results.
Okay, thank you. And thank you everybody for the answer. So it looks like most of the people think the incidence of acute kidney injury with COVID-19 is close to 15%. Thank you. So let's find out. I'll be talking about incidence and risk factors of AKI associated with COVID-19. So it's well known so far that COVID-19 is a multi-system disease. And as we are all aware, it's not only the lungs which are being affected by COVID-19. We also now know that it does affect major other organ systems, including the heart, brain, liver, as well as kidney. And we've had multiple reports on incidents of acute kidney injury seen with COVID-19. So as you can see on the slide here, the initial reports published in major journals, including JAMA, Lancet, and the New England Journal of Medicine, quoted incidents of COVID-19 associated AKI to be somewhere between 3 to 7%. However, it is important to note that all these cohorts had relatively low burden of comorbid illness, and also this incidence was mostly reported from China, only in the Chinese population, and the incidence of acute kidney injury in a diverse US population was unknown. To better understand about acute kidney injury in patients who were hospitalized with COVID-19 at our center, we felt that while we were taking care of these patients day and night here, it was also a research responsibility for us to let the world know what is happening here. So planning and preparedness can be done all over the world to make sure they have all resources to treat these patients. We studied the incidence of acute kidney injury, timing at which acute kidney injury would happen, risk factors for acute kidney injury, and the relationship of development of acute kidney injury to respiratory failure. Till date, in the United States, our study has been the largest, as it included close to 5,500 patients between the time of March 1st and April 5. And amongst these 5,500 patients, it was seen that acute kidney injury happened in a total of 37% patients. So about 40% of patients who were hospitalized with COVID-19 at our healthcare system did have acute kidney injury. And we also looked into what stage of acute kidney injury these patients developed. Stage 1 acute kidney injury is acute kidney injury where your serum creatinine goes 1.5 to 2 times above the baseline range. Stage 2 is when the creatinine increases 2 to 3 times from a baseline creatinine. And stage 3, which is the severest form of acute kidney injury, is when your serum creatinine is noted to go up by over 3 times from baseline creatinine. So amongst these patients who developed acute kidney injury, 11% actually had the severest form of acute kidney injury at our institution. The other strikingly significant finding was that the timing of occurrence of acute kidney injury did correlate with the initiation of invasive mechanical ventilation. What was seen was that most of the acute kidney injury which happened in these patients did occur right after the time of intubation. And it was also seen that the severest forms of acute kidney injury occurred in those who required mechanical ventilation. Around 90% of these patients who developed acute kidney injury required mechanical ventilation, and majority of these patients, around 97%, required kidney replacement therapy. these were also the patients who had respiratory failure. So it was seen that both respiratory failure and severe acute kidney injury requiring kidney replacement therapy or dialysis were interlinked. The various risk factors we identified in this diverse patient population included older patients, African Americans, those with underlying diabetes, hypertension, and cardiovascular disease, and definitely the ones who needed mechanical ventilation or use of vasopressor medicines. What was not found to be significant as a risk factor for development of acute kidney injury was the gender of the patient, history of chronic respiratory disease, obesity, history of cancer, chronic liver disease, or home use of ACE inhibitors or ARBs. So there have been several studies where obesity has been linked to be a poor prognostic indicator for patients who develop COVID-19. However, for the development of acute kidney injury in our hospitalized patients, this was not a significant risk factor. So then our next research question was, what is the reason for this kidney injury to occur? Why is this acute kidney injury occurring? And to look better into this, we did analyze the tests which were done on urine and what results were seen. Since the timing of acute kidney injury was linked to the timing of intubation, it was thought that most of this kidney injury was happening as a result of acute tubular injury or acute tubular necrosis. But what we found differently when we look back onto the results of urine samples in these patients who developed acute kidney injury was that more than half of the population, 66%, actually had low urine sodium, which goes against acute tubular necrosis, where you would expect to have a higher urine sodium. And also, a significant amount of this population did have presence of proteinuria and hematuria or urine dipstick analysis, which does indicate that there is probably more than just acute tubular necrosis, which was leading to development of acute kidney injury in our patient population. So just summarizing what we found here at Northwell with our study, again, we had 449 patients included in the study, out of which close to 2,000 patients or 37% were noted to develop acute kidney injury. We already discussed about the independent risk factors and going towards the outcomes of the injury. It was seen that 35% of patients who developed acute kidney injury in our cohort had mortality. So it was seen that acute kidney injury occurs frequently among patients with COVID-19. It occurs early and in temporal association with respiratory failure, and acute kidney injury in COVID-19 is associated with poor prognosis. So let's come back to our case. I'm just reminding you about the case a bit. We had a 64-year-old gentleman who presented with COVID-19 associated respiratory failure and developed acute kidney injury with creatinine of around 8 on presentation. And further workup showed presence of significant nephrotic range proteinuria of 5 grams seen on the urine protein to creatinine ratio, and also microscopic hematuria with 55 RBCs per high power field seen. CBC was pertinent for leukopenia. All his electrolytes were within normal limits. His serum albumin was low at 2.8 grams per deciliter, and other pertinent labs which we noted in this patient, including high levels of inflammatory markers like ferritin, C-reactive protein, and D-dimer. So when this developed during the workup of this case, of course, our nephrology fellow who was involved got concerned, came to me and said, I'm concerned about an intrinsic process being cause of AKI. Should we do a kidney biopsy? So let's see what all you.
I'm posting the second poll. You will have 45 seconds to answer. Please vote on your screen.
So this is a 64-year-old patient with acute kidney injury, respiratory failure in the setting of COVID-19, who has nephrotic range proteinuria and microscopic hematuria with low albumin. What do you think is the most likely cause of this patient's acute kidney injury?
Okay, I'll be ending the poll in under 5 seconds. Thank you. Sharing the results.
Okay, thank you for the answers. So I see majority of you think it could still be acute tubular necrosis, and about 30% of you also think this could be glomerulonephritis. Thrombotic microangiopathy, also another contestant with glomerulonephritis, but I see majority of you do not think this is just a pre-renal form of injury. Okay, so we can go ahead. So let's talk about etiology and pathology of COVID-19 associated kidney injury, what's known so far. So this is just a diagram to actually give you an idea what could be the possible mechanisms of acute kidney injury associated with COVID-19. And you can find this on nephronpower.com, which is a nephrology blog being run by our associate chief of nephrology here, Dr. Javeri. What he described here is that the etiology, the mechanisms for development of acute kidney injury seen with COVID-19 are multifactorial. It can happen to a pre-renal insult. It can happen due to a post-renal cause. But of course, if it's post-renal, it's not necessarily related to COVID-19 itself. But if you see the intrinsic kidney injury does play a major role in pathogenesis of acute kidney injury in COVID-19 as well. So we all understand now and are aware that tubular injury could be the most common cause since these patients have sepsis, they are hypotensive, they are requiring mechanical ventilation. So tubular is definitely something which is common as seen with any other severe form of infection. You can also see an allergic interstitial nephritis kind of process, which can generally be seen as a drug-induced mechanism, especially when we are using antibiotics in treatment of viral-related pneumonia, and those antibiotics can cause an AIN kind of picture. There have been some vascular events like renal vein thrombosis reported as well. And since we all have now learned that COVID-19 can lead to a cytokine storm, but at the same time, it might be a process which is causing a lot of clotting disorders. This is something we might be seeing more in the future as the cases come in and are being diagnosed. And then it's also seen that glomerular injury is also a another cause of acute kidney injury, where what has mostly been seen so far is either development of collapsing glomerulonephritis, causing a form of epithelial injury to the glomerular basement membrane, and you can even see a thrombotic microangiopathy when your endothelial membrane is affected. So this is another study from New Orleans here in United States, which is one of the earlier studies that looked at etiology of acute kidney injury in COVID-19 patients. They had around 500 patients in their study, and even in this study, the incidence of acute kidney injury was 28%, so close to 30%. These patients also required high rates of kidney replacement therapy, and the most common cause of acute kidney injury, the most common etiology seen in these patients was actually acute tubular injury. They did see some interstitial nephritis, some glomerular form of disease, some prerenal azotemia, but the majority, the chunk of AKI happened because of acute tubular injury. And as we were all learning, there were autopsy reports that came from China, where again, this was a study done on 26 autopsies in COVID-19 patients from China, where again, acute tubular injury was suggested as the most common cause of acute kidney injury. And the other significant finding which they reported was presence of viral particles, which they claimed to see on electron microscopy. So as these reports came, viral tropism for the kidney was another mechanism postulated which may have led to development of acute kidney injury in these patients. Once we had these initial reports from China, the next big question that came into picture was whether virus is present in the kidney or not, because this is still a controversial area. We still have conflicting reports on this section. As you see here, there have been multiple reports showing or claiming presence of viral particles being seen on the kidney. But at the same time, there have been similar reports which claimed that they did see something similar to what a virus particle could look on electron microscopy, but that is not necessarily a virus particle. So what has been our experience? As I mentioned before, the initial reports are all from autopsy studies, but here, since we did have a big patient population that was admitted and presented with acute kidney injury, proteinuria, microscopic hematuria, or other factors which led us to do kidney biopsies on them, we initially have reported a case series on 10 kidney biopsies. So these were all patients who are living. These are not autopsies. These are patients who were biopsied either in the ICU setting or on floors. We also found that acute tubular necrosis was the most common pathology, and some form of acute tubular injury was seen in all these patients. However, we also did see one patient having thrombotic microangiopathy, one with collapsing glomerulopathy, one with the presence of myoglobin casts in the setting of rhabdomyolysis, and another case with pauci-immune glomerulonephritis associated with ANCA disease or ANCA vasculitis. What we saw regarding the virus particles was that according to our kidney pathologists here, no virus particle was found in the kidney when the biopsy samples were stained for immunohistochemistry. But what is now known and what's now speculated is that these particles, which appear like virus on electron microscopy, are actually not virus particles, but these are something known as microvesicular bodies, which develop due to podocyte endocytosis, leading to subsequent formation of intracytoplasmic microvesicles. And it's actually these intracytoplasmic vesicles that can resemble the virus. However, when stained specifically for virus, they are not virus particles. And there came the statement from our kidney pathologist mentioning everything that has a crown is not coronavirus. So this is another proposed pathogenic mechanism for development of acute kidney injury, just recently published in Journal of American Society of Nephrology, where virus binding to ACE2 receptor has been described as the initial process by which the virus is able to get into the kidneys. And since ACE2 receptor plays an important role in regulation of angiotensin 2, because of virus binding to ACE2 receptor, there happens a decrease in expression of ACE2 receptor, leading to angiotensin 2 activation. And there has also been suggestion that the virus can directly invade into the tissue. With the activation of angiotensin 2, there occurs initiation of our inflammatory cascade. There is reduction in the angiotensin 1 to 7 levels. Cytokine storm develops, which can finally lead to a state of hypercoagulability and microangiopathy. And this is a mechanism which is also now described in various case reports that have mentioned about cardiac and lung injury happening in these patients. And at the same time, other common things which can cause acute kidney injury, including rhabdomyolysis, hypoxia, hypotension, can lead to either acute tubular necrosis or other intrinsic form of acute kidney injury in these patients. So this is another report which just came actually early this week, where people in the United States have looked at specifically patients who developed collapsing glomerulopathy as the cause of acute kidney injury in association with COVID-19. These include, this study includes 6 patients. What was seen here, the important thing, what was seen was that these were all patients belonging to African American race, and all were found to have APOL1 genotype present. APOL1 allele is actually considered already as a risk allele for development of collapsing nephropathy, especially seen with viral illnesses like parvovirus infection, etc. And the same finding was found in this study too. So this is something just to think of, just to know that patients who have APOL1 genotype, which is mostly seen in African American patients, do have a tendency to develop collapsing glomerulonephritis, which is one of the severest forms of acute kidney injury, having very less chances of recovery if not treated promptly. All right, so going back to our case. So since our patient had presentations of some intrinsic glomerular process going on, we did go ahead and perform the kidney biopsy on this patient. And the biopsy showed pauci-immune glomerulonephritis. At the same time, when we got results back for the biopsy, we also got results back for presence of P-ANCA and myeloperoxidase antibodies being positive in the blood samples. So this patient was diagnosed with ANCA-associated glomerulonephritis in the setting of COVID-19, and this is actually the first patient with ANCA described in the United States. At the same time, we also had another patient, not in our own institute, but in another institute here in New York, who also had findings of ANCA-associated glomerulonephritis. And both of these patients, when treated with immunosuppression, did well in terms of their overall clinical status, as well as in terms of outcomes for acute kidney injury. So let's talk about COVID-19 associated acute kidney injury and outcomes. Our biggest question here is to know what is the difference between patients with AKI compared to those who do not have AKI in terms of outcome. So if you see here, definitely acute kidney injury is a poorer prognostic factor, as 35% of patients who had acute kidney injury, as opposed to 6% who did not develop acute kidney injury, had mortality. And at the time when we concluded our initial acute kidney injury study, there were still 39% of these patients who were still in the hospital. So we actually have a better follow-up now and are looking into the follow-up time to see if that changed the outcome, since a lot of these patients who were hospitalized at that time have now either been discharged or not done well. So we will have a better idea. But our initial study did show that the mortality in patients who developed acute kidney injury was higher as compared to those who did not have acute kidney injury. What was seen for patients who required dialysis for acute kidney injury? So more than half of the patients who required dialysis due to any reason, who were admitted with acute kidney injury, had mortality, just indicating the same thing, that more severe acute kidney injury needing dialysis probably is associated with higher mortality. But of course, we do not still have the long-term follow-up, and with our upcoming study on outcomes with a longer time of follow-up, we may have some change in these numbers. So we talked about the overall outcomes in patients who developed acute kidney injury. Now let's talk about kidney-specific outcomes in these patients who had acute kidney injury. Before I go into it, I just want to let you know what our research questions here were. It was either to see the best scenario, which means complete recovery of your kidney function, completely kidney function going back to normal, or to see whether these patients are going to end up with some form of chronic kidney disease. And by definition, any patient who does not have a recovery from acute kidney injury for more than 3 months is labeled as somebody to have chronic kidney injury. And lastly, also to see if these patients are still dependent on dialysis, are not able to show any signs of recovery, and if they stay dependent on dialysis for over 3 months, they are going to end up having permanent damage, needing long-term dialysis. We still do not have the complete outcomes, but what we know so far here is represented on this graph. Let me walk you through it. So the purple color represents initial creatinine value with which the patients got admitted to the hospital. The green represents peak in the creatinine level, and the yellow represents the final creatinine level, which was seen in these patients at the time of discharge from the hospital. So what we found so far is that The peak creatinine and the final discharge creatinine for patients who developed stage 1 and stage 2 acute kidney injury, which are lesser severe forms of acute kidney injury, did not have the levels as strikingly high as the ones who developed stage 3 kidney injury or the severest form of acute kidney injury. Okay, so let's go back to the case. So our patient received pulse dose steroids and a dose of rituximab during his hospital stay. After the pulse dose steroids were given, he did have a marked improvement in his urine output and did not require any further dialysis. At this point, the patient has been discharged home. He is doing well. He's on decreasing requirements of oxygen. And his serum creatinine, if you recall, he had presented with a creatinine of 8 milligrams per deciliter. Right now, about a month later, the creatinine has decreased to 3.3 milligrams per deciliter and is continuing to decrease. So we are expecting him to have a better recovery in terms of both acute kidney injury and his overall clinical status. What happens to patients who are on chronic dialysis and develop COVID-19? So since we had a big chunk of end-stage kidney disease patients who got admitted to our hospital system, we were able to look at close to 11,000 COVID-19 patients, out of which around 4% had end-stage kidney disease and were either on hemodialysis, that was the majority of these patients, or on chronic peritoneal dialysis at home. What was seen was that the need for mechanical ventilation was similar in both groups, meaning the ones who were on chronic dialysis versus the ones who were not. But there was definitely a significantly higher mortality seen in patients with end-stage kidney disease on dialysis on presentation. The same study also included peritoneal dialysis patients, and we were able to extract data on these patients. First thing which was seen was that the number of patients who are on chronic peritoneal dialysis and required hospitalization for COVID-19 was way lower than the ones who are on chronic hemodialysis as outpatient. There can be multiple reasons for this. One major reason being that in this part of the United States, hemodialysis is still a more preferred, more prevalent form of outpatient dialysis modality that patients want to pursue. So overall, even at our center, we have lesser number of peritoneal dialysis patients who perform this at home as compared to the ones who come to our center for getting hemodialysis. The other possibility could be that since these patients perform PD at home, the exposure for these patients to community was way lesser as compared to patients who are coming to in center, getting exposed to other healthcare associates, other patients in the center, despite having all the precautions here. And also the peritoneal dialysis patients are constantly being reminded of the hygiene they need to maintain due to higher risk of development of peritonitis. So it's possible that they are probably just more vigilant as compared to our hemodialysis population. Out of these patients, a significant number, 3 out of 11, did require mechanical ventilation, with 2 mortalities, both happening for patients who required mechanical ventilation. However, majority of them were able to get discharged home without requiring any additional oxygen supplementation. All right, so let's go to the next question.
Launching the poll 3. All the attendees, please answer. The poll will stay for 45 seconds.
So with the patients in COVID-19, which of the following electrolyte disorder do you think might be a poor prognostic indicator?
Potassium.
Hyper.
Sodium to sodium. Sodium?
नहीं hyper के hypo.
Hyper की sodium urine hypo है तो उससे hyper हो जाएगा. वो देना everything ID.
5 more seconds.
Hello.
Okay, I'll be ending the poll now.
Okay, so most of you think it's possibly hyponatremia. Let's find out what we know at this point. Okay, so the entire world, including us, Europe, Asia, we are all still learning as reports keep coming. So far, what has been seen, what is known as that hyponatremia, hypokalemia, and hypocalcemia have actually been seen in patients who developed severest form of COVID-19 disease. And the role still needs to be elucidated. Whether these patients have higher mortality or not is yet something, a question that needs to be figured out. What has been described or speculated so far is the possible role of hypokalemia being a poor prognostic indicator or leading to development of severe form of COVID-19. It's known well that hypokalemia can exacerbate acute respiratory distress syndrome and can also precipitate acute cardiac injury. So it's possible that because of these known mechanisms, patients who are hypokalemic may tend to have a predisposition to develop lung or cardiac injury in the acute setting. And the pathophysiology for development of hypokalemia in these patients has been attributed to these patients having losses of potassium from the kidney as opposed to GI losses, and the mechanism has been linked to the binding of virus to ACE2 receptor, leading to decrease in ACE2 expression, and finally dysregulating angiotensin 2, increasing aldosterone, promoting the excretion of potassium from the kidneys. What about patients who have had kidney transplant? So there have been a few studies out from various transplant centers throughout the world. And what is known so far, which has been common presentation seen in all these studies, is that patients who have had an organ transplant do present in the similar clinical fashion as the general population does. So the most common presentation features for these patients are also presence of fever, cough, shortness of breath. So if any of your transplant patients call you with these symptoms, they definitely should be screened or ruled out for COVID-19. We still don't have definite guidelines for immunosuppression. However, in most of the literature that has been reported, it's mentioned that immunosuppression for these patients who developed COVID-19 and had an underlying organ transplant, the immunosuppression was discontinued or reduced at the time of diagnosis, and usually it's the anti-metabolite, which is either the mycophenolate and even leflunomide. These two drugs are the major ones which were held to decrease the immunosuppression. Majority of these patients did get treated with hydroxychloroquine as the COVID-19 therapy. However, ideal treatment still remains unknown. and the mortality for these patients has been reported to be somewhere between 20 to 30%. But keep in mind, the mortality data is all based on hospitalized patients. So there are still patients with transplant who have been able to recover at home, but definitely the mortality for patients who were sicker, who needed hospitalization, has been as high as 30% so far reported. Okay, so let's take this next question. We have a 41-year-old male with COVID-19 who gets intubated on admission for severe ARDS. He becomes hypotensive with increasing requirements of vasopressors. He becomes bradycardic, oligoanuric, with rise in his creatinine to 3.8 from a creatinine of 0.6 on admission, and is noted to also have hyperkalemia with potassium of 7.8. This is when we as nephrology get consulted. What would be the next step in treatment of this patient? And I'll just have Dr. Dharwarkar give the options. Okay, so we have a middle-aged man here who is intubated, hypotensive, on pressors, on increasing oxygen requirements due to severe ARDS, now develops anuric acute kidney injury with hyperkalemia. What would be the next step in treatment of this patient? And this is again an actual scenario. This is similar to what we were getting consulted for during the COVID crisis, being nephrologists, while we were seeing a lot of acute kidney injury, a lot of electrolyte problems developing in this subset of patients.
Five more seconds. Sharing the results.
Okay, so I see that actually half of the participants would say this patient should be right away started on hemodialysis. So, I mean, it's different. Different in different settings. For us logistically, since this patient was in the ICU and our inpatient hemodialysis nurses were overwhelmed to catch up with the amount of hemodialysis they were dealing with, our best scenario was to actually initiate the patient on CRRT. So we just did 2 hours of hemodialysis followed by CRRT in this patient. Just to give you an idea of what exactly happened to our inpatient nephrology services during the COVID-19 surge, which did happen in end of March, beginning of April, in our healthcare system here in New York. And this is just to let you guys know of it so you can have preparedness for ongoing COVID-19 outbreaks or for any future resurgence if happens. What we noted was that the total number of hospital admissions actually declined during the COVID-19 surge. So it's possible that patients were scared to come to the hospital because they had the fear of contracting COVID in the hospital setting. It's also possible that a lot of elective procedures, major surgeries were cancelled because of the COVID-19 surge. So we were not getting too many hospital admissions from the surgical standpoint. Despite decline in hospital admissions, the daily nephrology need for consultation did go up, and also there was a rise in daily need for inpatient hemodialysis as well as daily need for continuous renal replacement therapy. And actually, the need for continuous renal replacement therapy increased 5 times when patients of COVID-19 were hospitalized and needed to be in the ICU setting. During the peak COVID-19 week, we did see a 56% increase in daily requirements of hemodialysis in the hospital, but the daily need for continuous renal replacement therapy actually increased over 500%. This was because these patients had severest form of COVID-19, had bad lung disease, needing intubation, pressor support, and these were also the ones who would not have been able to tolerate hemodialysis. So we did have to cope up with this and make sure everybody who needed it got it. I just want to share the picture here. These are our dialysis nurses who, despite being busy working 24 hours with sick patients, seeing a lot of mortality, were still able to maintain smiles on their face and serve the humanity. So really big thanks to the dialysis nurses here. And how did we respond to this surge? So this is also important to know, so we can have a plan for future preparedness in case there is a resurgence or even for ongoing COVID-19 breaks still happening in different parts of the world. We stuck to a belief that no patient should die due to lack of availability of dialysis equipment or supplies. So while we were entering the phase of COVID-19 crisis, while the patients were starting to come in, getting hospitalized, our health system was able to purchase new hemodialysis machines as well as CRRT machines, since we knew from the experience in China that these patients probably will require these services. And then March through June, when we had the actual crash week, which was beginning of April, specifically in the second week of April, we did have to change our strategies a little when we came to another system of cohorting, where actually we had one dialysis nurse taking care of multiple dialysis patients who were started on the dialysis at same time, ending at same time, and had similar prescription of dialysis. Also, SLED is a modality which we do not usually practice here since we do have access to CRRT. However, because we can use a non-CRRT machine for SLED, we did go back to using SLED for the patients to make sure that every patient who needed it did get some form of kidney replacement therapy. So just my concluding slide to summarize what we have seen here, and might be also something which is being seen in other parts of the world. Acute kidney injury in our patient population here was seen to occur in about 1/3 of patients who were hospitalized with COVID-19. The severest forms of acute kidney injury occurred in those who required mechanical ventilation. Most common cause of acute kidney injury we saw here was acute tubular injury or acute tubular necrosis, and the most common glomerular pathology associated with acute kidney injury in COVID-19 setting that has been reported so far is collapsing FSGS. Patients with end-stage kidney disease who developed COVID-19 did have higher mortality as compared to those who do not have end-stage kidney disease. Regarding our kidney transplant population, our transplant recipients, current recommendations do mention to reduce their immunosuppression if they are diagnosed with COVID-19. And the most common electrolyte disorders which have been reported so far with severe COVID-19 include low sodium, low potassium, and low levels of calcium. I just want to acknowledge my entire nephrology division, without whom being able to do the research and come up with outcomes would not have been possible. And especially want to acknowledge Dr. Eng, Dr. Hirsch, who are also actually epidemiologists and bioinformatic people who helped in analyzing the data at a good speed, and my associate chief, Dr. Javeri, and chief of nephrology, Dr. Fishbane, without who none of us would have been able to survive this crisis. I do want to acknowledge all my nephrology fellows, without who we could not have survived, and we actually call them super nephrons. You see them smiling even when they were working tirelessly all the day, round the clock, thanks to them. And this is actually the group picture in today's world, which we took during their virtual graduation, as we were not able to do the ceremony in person. Lastly, I also want to thank my entire family, including my parents and my in-laws back in India, who extended their continued support during the crisis, and especially my husband and my son, without whose cooperation I would not have been able to do and prepare for this at all. Thank you, and I'll just open it up to you all for any questions.
Thank you, Dr. Nupur. It was a very sweet and lucid presentation, and the best part was you walked us through the case and gave us your first-hand experience on this issue. May I request Dr. S.K. Sadavate sir to please ask any query or anything if you would like to ask to Dr. Nupur. Sadavate sir.
Hello.
Yes, sir. You're audible, sir.
Hello. I'm audible? Yeah.
Yes.
Okay, Nupur ma'am, it was an excellent comprehensive account of COVID-19 in relation to the renal problems. It was an excellent lecture. Ma'am, I would like to ask you, can you, still more put a light on the immunosuppressive patients with COVID-19?
Sure. Thank you, Dr. Sadavate, for the question. So the patient population from a nephrologist standpoint that I deal with who are on immunosuppression are mostly the patients who are kidney transplant recipients, or the ones who are receiving some form of immunosuppression due to certain types of glomerulonephritis. So going back to the kidney transplant recipients, there have been questions about holding their immunosuppression or reducing their immunosuppression with the idea to make them less immunosuppressed, as they are considered to have a higher risk of infection being immunosuppressed. But at this time, for prophylaxis, we are not suggesting, and I think this is also something similar to what is happening in India, as I have been in contact with some transplant nephrologists in India. For prophylaxis, at this point, there is a suggestion not to hold the immunosuppression, because at the same time, the major problem which can arise by lowering or holding immunosuppression is they can actually have a rejection of the organ, needing them to come to the hospital, and actually the risk of contracting COVID-19 might be higher if you are exposed to multiple people in the hospital than staying home. So for prophylactic part, there is no recommendation right now to hold the immunosuppression for these patients. But once they get diagnosed with COVID-19, once we know these patients have COVID-19, what has been done and is being done is that generally we stop the mycophenolate, which is the anti-metabolite agent these patients are on. But the other agents like calcineurin inhibitors and steroids, chronic steroids, with these patients are getting, they are continued to maintain some degree of immunosuppression, but at the same time, lowering the immunosuppression by stopping the anti-metabolite agent, just to keep a balance of keeping them immunosuppressed, but also not keeping them too immunosuppressed to increase the risk of infection. And this is similar to what we generally do when a transplant patient gets hospitalized due to any infection, be bacterial or
Thank you.
viral. Yeah. Thank you.
Thank you.
Thank you, sir. Thank you, Dr. Nupur. Thank you, sir.
Thank you.
May I request Dr. Major V.K. Yadav, sir, to ask any query or add on to what Madam said?
Okay. Good morning, Dr. Nupur.
Good morning. Thank you.
It was a nice, lucid presentation. And being a pharmacologist present on the panel, my question is related to pharmacology. Suppose if a patient is already on some medication, for example, hydroxychloroquine, as being mentioned in your slide also, is there a requirement for the adjustment of dosage if this patient present with COVID-19 induced AKI?
Okay, thank you for the question. It's a very pertinent question and does come up a lot. So we are talking about patients who have COVID-19 and develop acute kidney injury. Going to your question, as far as changing or adjusting the doses for patients is concerned, from COVID-19 standpoint, to my knowledge, there is really no need to adjust or change the medications. But definitely, if these patients are presenting with acute kidney injury, it depends on the creatinine clearance. And generally, for patients who develop a severe form of acute kidney injury and require dialysis, we dose medicines to a creatinine clearance of less than 10, and it's similar recommendation for these patients too. As far as hydroxychloroquine in particular is concerned, patients who are taking hydroxychloroquine due to any reasons like systemic lupus or other rheumatological or autoimmune disorders, for prophylaxis, definitely no requirement to change the dose. And as far as getting COVID-19 and acute kidney injury is concerned, the dose just needs to be adjusted according to the creatinine clearance.
Okay, madam. Thank you.
Thank you. Thank you for the question.
Thank you, sir. Thank you, Dr. Nupur. May I request Dr. V.K. Sharma, sir, the epidemiologist panelist on our panel group, to please ask any query or clarify. Sir.
Good morning, Dr. Nupur. Thanks a lot for a very lucid presentation.
Thank you. Thank you.
As an epidemiologist, my worry is that do we expect increase in the number of kidney patients over the years? Because now whatever your study has been done on the hospital-based patients. What about the mild and moderate cases who might get subclinical injuries and may have later sequelae? So I mean the increase in the kidney disease burden in the society.
Yeah, thank you. Thank you for the question, Dr. Sharma. Very relevant. But, I mean, do we expect the burden of chronic kidney disease to rise at this point in association with COVID-19? In terms of what we have seen so far, and again, I am just going back to beginning of March, that's when we actually started seeing these patients. So it has been only close to 4 months since the initial patients got hospitalized. At this point, we have seen a few patients who actually completely recovered, but our feeling is that those were also mostly the patients who developed acute tubular necrosis. And we did see even in sickest patients who were intubated for close to a month, needing CRRT, there are a few patients who actually have had complete recovery of their kidney function now. But at the same time, we are still following up with patients who are coming to our clinic after getting discharged from the hospital, where the creatinines have not returned back to normal range and are either plateauing around 2 to 3 range, or these might be actually the subset of patients who may end up having some irreversible form of kidney, leading to development of chronic kidney disease and increase in the population. And also at this time, there are still a few patients who are dialysis dependent, requiring dialysis as outpatient, even though overall their clinical status has much improved, and from a lung standpoint, all the findings have resolved. So at this point, I do not have the exact answer to your question, but just looking at how things are progressing at this point, we do expect that we might end up seeing more patients who develop chronic kidney disease with COVID-19.
Thank you very much.
Thank you, Dr.
Thank you,
Sharma.
sir. Thank you, sir. Again, thank you, Dr. Nupur. May I request our panelist, Professor of Medicine, Dr. Shefali Bansal ma'am, to please ask any query or add on to what is being said. Madam.
Good morning, and thank you, Dr. Nupur, for enlightening us.
Thank you, Dr. Bansal. Thanks a lot.
To gain from your vast experience, a very small question to you. We know that ACE2 enzyme is the functional receptor for SARS-CoV-2, but select preclinical studies have suggested that RAS inhibitors may increase ACE2 expression. This raises concern regarding their safety in patients with COVID-19. Moreover, hypertension is a bad prognostic factor for mortality in COVID-19, and many patients are on RAS inhibitors. A special report published on March 13 nejm.org suggests that abrupt withdrawal of RAS inhibitors in high-risk patients, including those who have heart failure or MI, may result in clinical instability and adverse outcomes, and has advised to continue RAS inhibitors in stable patients who are at risk for or evaluated for COVID-19. In this context, what is your take on the safety of use of these drugs in the present scenario? And to continue a little more, I would just like to ask for people at large, but do you recommend to switch, or does the switch translate into terms of clinical benefit in patients who are COVID positive?
Thank you, Dr. Bansal, for the question. Again, excellent question, and we did get calls even from our patients who were taking ACE inhibitors or ARBs with similar discussion as you already quoted right now. And I am in touch even with the nephrologists, cardiologists, and internists, even in India. So I know that this question does come up quite frequently. Coming to your initial question first, I think you asked me if it's safe to continue the patients on ACE inhibitors or ARBs. So, as you rightly mentioned, that the ACE2 receptor has been proposed to play a major role in pathogenesis of multi-organ processes which are happening in association with COVID-19. And it has been postulated that the virus binds to ACE2 receptor, and that helps in the virus to enter into the tissue. So just giving you a little bit more idea about what ACE2 receptor does. What ACE2 receptor basically does is regulate the angiotensin, and if there is going to be any change in ACE2 receptors expression, there's going to be dysregulation of angiotensin. So you're absolutely right that there have been different schools of thoughts, and mainly there is a school of thought which considers stopping ACE or ARBs being beneficial, but at the same time, it is also now postulated that stopping these medicines might be harmful. The reason why it is considered that this might be harmful is that it is now known that the angiotensin 2, if it gets activated, it can lead to increased lung injury. And if a patient is on ACE inhibitors or ARB, that actually helps in reducing the angiotensin 2 levels, which in subsequence will lead to decrease in lung injury. So whether it's safe to continue ACE and ARB in these patients, I would say yes. We do not stop the ACE or ARB for patients who are already taking ACE inhibitors or ARBs. Of course, whether these are drugs which should be started as new drugs for patients who come in with COVID-19, that's still a gray area. But especially if the patients are coming in with acute kidney injury, we do not start them on these medicines. Of course, it's possible that maybe later in course of the disease, we might introduce these agents as needed, but definitely not in the acute phase of kidney injury. But the patients who are already taking these medicines, we continue them on these medicines. And your second question was about switching the antihypertensive. To my knowledge, what I am aware of so far, I don't think there is a particular antihypertensive agent which has shown to be of any benefit in patients who develop COVID-19. And for outpatients, for patients who are taking ACE inhibitors or ARBs, I would suggest, and this is again with the current guidelines from Europe, US, and Canada, that ACE and ARB therapy should be continued for hypertension, just because of the potential beneficial effects of decreasing the amount of lung injury. Plus, we are also aware that these are not just used for antihypertension. We know they also help in reducing the risk of cardiac injury. They help as cardioprotective and renoprotective medicines too. So patients who are taking it, we have them continue it and not switch it to other agent.
Thank you so much.
Thank you, Dr. Bansal.
Thank you, madam. Thank you, Dr. Nupur again. May I now request Dr. Manjunath Motki sir to please ask his query?
Good morning.
Dr. Manjunath sir?
Am I audible to you? Good
Yes,
morning, madam.
yes,
Am I audible to you?
Yes, Dr. Manjunath,
It was
yes.
a very informative presentation.
Thank
I
you.
have two questions to you. There are so many drugs being tried, starting from hydroxychloroquine, so many antivirals. Now dexamethasone they have been reported. What is the standard protocol as of now in your view? And this is the first one. Second one, is there any relation between the viral load in the urine with acute kidney injury?
Okay, thank you for the questions, Dr. Manjunath. So your first question was regarding the protocol for treatment, right? Treatment for patients. Okay. So at this point, what we are doing here is for patients who do not need hospitalization are actually just being asked to stay home, quarantine themselves, and recover at home. The only additional thing we have them do is monitor their pulse ox just to make sure what their oxygen saturation levels are. And if they see a drop in oxygen saturation levels, they are advised to get to the nearest emergency room right away. As far as drugs are concerned, for patients who are able to stay home, who are not that sick, at this point, they are not being treated with any antibiotics or even hydroxychloroquine. So the treatment for them is totally supportive, like you would do with any other viral infection. So completely supportive treatment for them. For the patients who get hospitalized, our health system has been making dynamic changes depending on what data comes over. But currently, what we are doing is hydroxychloroquine has fallen out of question because initially there were patients who got treated with hydroxychloroquine and it was not seen to be useful. So here in the United States, neither healthcare workers are getting it as a prophylaxis, nor are we using it anymore for patients who get hospitalized. But yes, it was used as the initial management drug for patients who got admitted early in March and April. Again, we don't know. I mean, it might still be the drug which helps, but we just did not see any benefit here in our population. Uh, Remdesivir is another agent which has been talked about a lot. There have been studies. That's still something we are using, but it's also based on the trial recommendations. It's not something which all the patients get. There's a very strict inclusion criteria for patients who get remdesivir, and generally patients who have severe acute kidney injury are not given remdesivir just because of the way the trial has been designed by the drug company. The other major thing we are using at this point is tocilizumab, which is an interleukin 6 inhibitor, and the purpose behind using it is to decrease the inflammation, which is thought to be the underlying pathogenic mechanism. So the main agents which most of the patients are getting who present being sicker include, I would say, just tocilizumab. Definitely nothing specific for the virus. So we are not using the protease inhibitors anymore. We are not using hydroxychloroquine anymore. Steroids is individualized. Of course, if patients have bad respiratory failure, they are being treated with corticosteroids. What we use here is mostly solumedrol. Dexamethasone has not been tried here. And as far as remdesivir is concerned, that's based on the inclusion criteria, which is still very strict. I hope that answered the question. And sorry, what was your second question?
What about the viral load in the urine? Is it related to the acute kidney injury?
So what we know about our patients from here, we have not tested a lot of patients for the viral load in urine. The test is still the nasopharyngeal swab for PCR for acute phase, or the other test we are doing is detecting for antibodies in the serum. But from what I know so far, and again, this data keeps changing, from what I'm aware of, there has still not been much reported about presence of higher viral load in the urine being a risk factor or a prognostic indicator. But that's just something that I know so far. There might be something coming up in the future.
Thank you very much.
Thank you, Dr. Manjunath.
Thank you, Dr. Manjunath, sir. Thank you, Dr. Nupur. Again, it was awesome interacting with you on all the levels. So we have had elite panelists who also helped us get enlightened with their queries on the said topic. I take this opportunity to thank you once again, Dr. Nupur, for a very crisp and lucid presentation, and all my panelists, elite panelists who have taken their time out to be present over on this podium. Last but not the least, definitely our People's University and management who have provided this podium. I thank you all once again. Dr. Nupur, so if anybody has any doubts or anything, Dr. Nupur has put up her email ID, so you can definitely contact her, or you have our IDs, you can do contact us anytime you want. Thank you for a wonderful session.
Thank you again, Dr. Dharpadkar, for the wonderful conduction. And I also thank all the panelists for their great questions and for enlightening us all. Thanks again to People's University for giving me this opportunity. And I just wish everyone good luck so we are all able to come out of the crisis situation and be back to our normal lives.
Definitely. Such a Okay, thank you.
Thank you so much. Thank you very
Okay.
much.
Thank you. Thank you.